To build on case one, we'll take a look now at case two. So case two is a much more stereotypical hyperkalemic patient. So someone who has missed a number of dialysis appointments. We have fairly clear-cut evidence that this patient would likely be experiencing hyperkalemia based on the fact that they have chronic renal failure and they have not been going to the treatments that are necessary to prevent hyperkalemia for these patients. So we'll do is very similar to case one is we'll take a look at the rhythms. When we look at rhythm interpretation number one, what we likely can all agree on is that this is, again, a fairly clear-cut sine wave. So here we're looking at a rate of around 60, sometimes slower, and we've got a wide complex. And we know that that is characteristic of the sine wave in hyperkalemia, and that is the result of potassium levels becoming higher than threshold, resulting in closure of sodium channels and prolonging phase zero to the point where our QRS complexes become extensively wide, which then leads to that sine wave rhythm. What's interesting about this case is that we then go to rhythm interpretations number 2 and number 3. And if we read the case, we'll recognize that these came after a series of treatments, one of them being epinephrine, as well as giving the patient both Ventolin and calcium gluconate. And what we should recognize here is that both rhythm interpretations number 2 and number 3 are greater than 100 beats per minute. So we have them being greater than 100 beats per minute, and they are wide complex. And when we have a rhythm that is greater than 100 beats per minute and is wide complex, it has to be shockable. So we can define this as a shockable rhythm. And again, what you might be thinking is, well, is this just a fast sine wave? And one of the things we have to recognize is that that doesn't really matter. If the complexes are wide and the rhythm is over 100, then it's impossible to say that this is not V-Tach, or it'd be impossible to tell the difference between, a really fast sine wave versus a true ventricular tachycardia. That's the result of reentry pathway. So it becomes shockable. And we're going to talk about kind of 3 of the ways in which we can get this shockable rhythm as a result of hyperkalemia. So how do we end up going from a sine wave to going into a shockable rhythm? And should we be shocking those rhythms? The first one is the role of epinephrine. So we talked before about epinephrine being one of those things that can take a sine wave and make it much faster. We know that epinephrine is going to act on the pacemakers and it's going to increase rate while not necessarily leading to a more narrow QRS complex. So as a result, we can go from this kind of wide complex slow rhythm, or the sine wave rhythm, to giving epinephrine and getting this really fast wide complex rhythm that is indistinguishable to ventricular tachycardia, and because of that should be shocked. One of the other things that we have to think about for this patient is the treatment with calcium gluconate. So I'm going to use this blue line to represent what calcium gluconate does for patients who are hyperkalemic. We know that when we're looking at our typical myocardial action potential, our threshold lives down here. When we give someone calcium gluconate, the whole goal is to take that threshold and to move it up. So we create a new threshold line, which should basically help some of these issues that we're seeing. So calcium gluconate takes the threshold and moves it up over the resting membrane potential in the hyperkalemic patient. So we knew that our myocardial resting membrane potential went way up here. So we just say, well, let's move the threshold up above that, and that should solve some of our problems. And it does. It promotes opening of our sodium channels, and we typically can see a more normal rhythm for that patient. One of the things that we do have to think about is in this process, as we're moving that threshold up, there will be points in time where that threshold is very close to our resting membrane potential. And the closer that the threshold is to the resting membrane potential, the more irritable the ventricles can become. And as a result, we can see V-Tach or VF being present in the patient who's hyperkalemic. This is one of the reasons why, if we have the renal failure patient who is in ventricular tachycardia or ventricular fibrillation, we should consider hyperkalemia as one of the causes, is because in early hyperkalemia, we do see exactly that, the threshold being very close to the resting membrane potential. And that can increase irritability. So one of the other ways where we can get shockable rhythms in someone who has hyperkalemia is either in early hyperkalemia or following treatment. What we can see is the resting membrane potential become closer to the threshold. And what this does is it promotes V-Tach or VF. Finally, when we're looking at the third way in which we can see shockable rhythms in these patients, is they are still patients who are in or near cardiac arrest and who have an extensive irritability to the ventricles. So we have to remember that these patients are still experiencing hypoxia, acidosis, other electrolyte imbalances, and myocardial cell death. That is going to make their heart more irritable and more likely to present with a reentry or a tachycardia or V-Tach or VF. So what is the point of this, or what's the point we're trying to get across? One is that we know that we will see our sine wave rhythm in our hyperkalemic patients, or could see that, but we also have to appreciate that it's not uncommon for them to be in shockable rhythms. And when we have a wide complex rhythm over 100 beats per minute, we should shock it. And what we see sometimes for missed defibrillations is as the rhythm is speeding up and remains wide, we're missing those defibrillations as we're looking at saying, well, that's just a sine wave or a fast sine wave without considering the rate. If the rate is over 100, this now becomes indistinguishable from a V-Tach, and we should be shocking it. And we can see that in this case. So what could the cause of that be? Like we said, it could just be the epinephrine resulting in increased rate of our sine wave, which would still make it a ventricular tachycardia. It could be that our treatments are making the threshold closer to the resting membrane potential, so the heart is more irritable and prone to V-Tach, so we could actually be seeing a true V-Tach here. Or because the patient's in cardiac arrest, they're experiencing hypoxia, acidosis, electrolyte imbalance, myocardial cell death, they could be just more irritable, which again makes them more prone to V-Tach or VF, and we should be shocking those rhythms. So when you're dealing with a hyperkalemic patient who's in cardiac arrest, what we should be thinking about is the rhythm wide? Is it a fast speed or over 100 beats per minute? If it is, we'll shock that patient and we will continue on with our typical treatments for hyperkalemia. So be considerate of rate, especially when you start out with that sine wave rhythm. We need to be mindful that just because it's getting faster doesn't mean that it's just a fast sine wave. It could proceed past that point of that 100 beats per minute, could enter a wide complex tachycardia or ventricular tachycardia, which would be eligible for defibrillation.